How do surgeons prevent SAM when they're performing a repair? The question I would ask myself is, what is the risk factor for SAM and what can be done to address it? First off, the goal is to achieve the optimal coaptation length. Again, this is 4 to 10 millimeters, but really optimally it's 8 to 10 millimeters. Over that, you can have too much redundant tissue that predisposes to SAM. The second is to reduce posterior leaflet height. The goal for a surgeon is less than 15 millimeters. Remember, reducing the posterior leaflet height moves the coaptation point more posteriorly, which would actually increase that C-sep distance. To reduce the posterior leaflet height can be performed with neocords, resection, or even a sliding plasty. In regards to picking a ring, a large true-sized ring or band is less likely to cause SAM than a downsized one. If a ring is undersized, that anterior mitral leaflet will not spread out, and that redundant tissue can predispose to SAM, and it also displaces that posterior mitral valve annulus more anteriorly, bringing it closer to the left ventricular outflow tract. Also, a partial ring is better in SAM prevention than a complete one. This is because during systole, the base of the anterior mitral leaflet actually moves posteriorly to increase the size of the LVOT, while the insertion of a complete ring at this area of the heart eliminates this movement, causing a narrower systolic LVOT diameter and favoring SAM. The surgeon can also further perform septal myectomy or edge-to-edge sutures to help prevent SAM. What happens if you have SAM after you've come off pump for mitral valve repair surgery? There's a few steps you're going to walk through. Essentially, in the treatment of any SAM, you want to pursue medical treatment first. Give fluids to fill the heart. Slow the heart rate down, which also fills the heart. Stop inotropes and even potentially give esmolol. Increasing the afterload can help stent open that LVOT. In most cases, SAM will resolve with conservative management. And if you have an elevated gradient, this will normalize over weeks to months. So my thought here is do everything I can medically to improve it. And if I see an acceptable result, we're going to take that. However, if you still have significant SAM with significant LVOT obstruction despite optimizing medical management, it may warrant re-repair. There are a couple re-repair strategies if you have SAM after you come off pump. A lot of these are based on trying to move that coaptation line more and more posteriorly. This would include upsizing that ring even more, performing a neocord or resection to reduce that posterior mitral leaflet height, and also even using an edge-to-edge stitch, also called an Alfieri stitch, to stitch that anterior and posterior leaflet together in the middle to help prevent that anterior leaflet from being drawn out into the left ventricular outflow tract.